Right, so today I was going to talk about things maybe that we don't always talk about or think about. A lot of, a lot of doctors even probably don't talk about it enough with their patients. Really, really about how to keep yourself healthy from getting sexually transmitted infections, things like HIV, which again, we don't talk about openly, probably enough. So I'm going to start talking a little bit about HIV. We'll talk about something called pre-exposure prophylaxis. That's a type of medication you can take to prevent HIV. We'll go over who might be a candidate for that. Then we'll talk about the importance of screening for other sexually transmitted infections. I'll briefly review that. And then we'll talk about something called post-exposure prophylaxis, which means after you've maybe been exposed, what you can do to lower your risk of catching something. And then we'll finish, with some strategies about how else to keep safe in this kind of, crazy world we live in, right? A little bit about myself. From New Jersey. I went to medical school in the city at NYU. I did my training down in New Brunswick. Then I went back to the city. I did a fellowship in infectious diseases at Memorial Sloan Kettering Cancer Center. And then out of training, I joined Englewood Hospital in 2008. So I'm part of a practice called Leonia Medical Associates, where I see patients in the office and in the hospital. I was chairman of infectious disease from 2018 until 2024, and I still chair the Infection Prevention Committee. So I'm very involved, and I have a vested interest in prevention of these things that I do see in the office all the time. HIV has been around a long time, right? I think most of you are probably old enough to remember back in the 80s when it first came out. It was very scary, right? All over the news. We didn't have any treatments. Back then, if it was 1985 and you contracted HIV, it was a death sentence. The average person probably had about 10 years to live before this virus attacked your immune system, and you would ultimately succumb to a variety of infections. There was no, even diagnostics were limited, treatments, there were none. That all changed in 1987 when we had our first therapeutic for HIV. It would extend your life. Actually, the very first medicine extended your life by 6 months. So someone that was thinking they were going to die, on average, would gain an extra 6 months. We've come a long way since then. Over the years, we've developed very effective treatments. The big change came in around 1995 when they developed something called highly active antiretroviral therapy. So HIV went from being a death sentence, from 1985 to today. If you get HIV, you live with it. It's a chronic disease, just like high blood pressure, diabetes, heart disease. Unfortunately, a lot of people don't have great access, or there's not awareness of all the treatments. We still want to prevent people from getting HIV, and I'll get into that in a moment why, because it is medication you have to take for the rest of your life. So it's always better to prevent it than to wait to get it and treat it. So there's still a lot of patients. These are statistics just for the United States. So there's over 30,000 patients every year, newly diagnosed HIV patients. That's a large burden if you think about it. Larger than it should be, in my opinion.
Is that just the U.S.?
That's just the United States. Worldwide, it's much higher, especially if you account for like sub-Saharan Africa and some other pockets of the world where it's much higher. We have over 1 million patients with HIV in the country right now. And one of the scary statistics is about 13 to 15% don't know they have HIV. So you're talking about 150 to 200,000 patients who are potentially spreading it to others and don't know. And part of that is when you first get infected with HIV, there's often no symptoms, right? You feel fine. It's not until years later when you start to demonstrate symptoms. So in that period of time, these patients, unfortunately, can go on to infect many others, right? So that's part of the challenge we face. And the other problem we face, which I alluded to earlier, a lot of patients, even when they have HIV, they don't get put on meds or they can't stay on meds for a variety of reasons. Sometimes financial, they can't afford the medications, they don't have insurance, there's lots of barriers. And when someone has HIV and they're not controlled, again, they can pass it on to others. Mother can pass it on to child, so forth. So there's lots of areas we have to improve to try to prevent this. Unfortunately, there is no vaccine for HIV, right? I think I said that before. They've been looking for a vaccine for HIV for decades. And every time we get a trial, everyone gets excited, and then it ends up not working out. I'm hoping someday that happens, but so far that doesn't seem to be in the cards. And there's no cure either. So I said there's medicine that controls it, does not cure it. So if you get HIV and you get put on medicine, you're on medicine for life. And one thing we're learning is that the medicines do have side effects. I have patients that have had HIV for 30, even 40 years. And what they deal with now is not the side effects from HIV, but the medications. The medications can cause kidney problems, bone problems. Some of the medications can cause heart disease. Obviously, we have to keep them on medicine because HIV can be even worse, but it's not an ideal situation. So this is where the idea for PrEP, or pre-exposure prophylaxis, came about. HIV, everyone understands how HIV is transmitted. You know, the people at risk for HIV, there's a bunch of different buckets we kind of look at. We used to worry about blood transfusions. If you all remember way back when, everyone used to be scared to get a blood transfusion. What if you contract? These days, it's almost a zero risk because the blood is screened. So you don't have to worry about blood transfusions being the vector. Needle exposure tends to be a big one, especially among drug abusers. When they share needles, oftentimes that's one route. We see outbreaks sometimes if there's a tattoo parlor that's not practicing proper techniques, you know, they reuse needles, things like that. We've seen outbreaks like that. The biggest driver, though, is probably sexual spread, unprotected sexual spread. So if someone that doesn't use condoms, a person that has multiple partners, so all those kind of behaviors increase the likelihood that you may contract this. The recommendation from the CDC and the United States Preventative Task Force used to be that all adults should be screened at least once in their lifetime for HIV. Screening for HIV is very easy. It's a simple blood test. Unfortunately, a lot of doctors don't always offer it, right? So as a patient, I'd encourage everyone to be proactive. You know, you can't wait for your doctor to ask you, do you want an HIV test? You can ask, Doc, can you also add an HIV test? And sometimes that helps spur the discussion about, you know, about sexual infections and risks and getting screened, which again we'll get into in a little bit as well. And I forgot the last kind of bucket that we look at patients is we have couples sometimes where one partner has HIV and the other one doesn't, like a husband and a wife or a husband and husband. You know, sometimes in those settings we like to give the negative partner medicine also to prevent them from contracting.
I have a question.
Yes.
What about, I would think, expected mother would
Yeah.
give it to the baby.
Oh, correct. Yeah, I didn't mention that. But
Right.
so all women should be screened also during pregnancy.
So we have a blood test, it's not automatically part of the lab?
It is. You know, it's part of most hospital protocols that during the pregnancy the mother gets screened. And if they're positive, there's very effective medication the mother and the baby can receive at birth to reduce the risk of transmission almost to zero. Yeah. So again, another reason to be screened. So I was talking about PrEP before, right? So what they did was about 15 years ago, they studied a medicine called Truvada, which is actually a medicine used to treat HIV. And they did a trial, actually all these trials tend to start in sub-Saharan Africa because they have some of the highest HIV rates in the world. And they gave a group of people Truvada once a day, and a group of people they didn't do anything, gave them placebo. And they watched to see how much HIV conversion there were in both groups. In the Truvada group, there was about a 50 to 75% reduction. So it clearly reduced the risk of people contracting HIV. There were more trials done in the United States. and on that basis, this was approved. So this was the very first time we had a medicine we could offer at-risk patients to try to prevent them and keep them safe from getting HIV. So it was a big milestone. Most of the time, we give PrEP as a pill every day. There are options for some people to take it on demand. So if you have a new partner, a new exposure, you take it for a period of 3 days, 2 pills the first day and then 1 pill the next 2 days. That also seems to work, probably about as well as taking it daily, but it was only studied with homosexual men. So we can't make it a blanket recommendation for other populations. And the other worry about that is if you forget to take your pills, whatever, and you miss the boat. So I'm not a huge fan of that approach, though it is a valid option for some people. About 7 years later, there was the next medicine that we got for PrEP, something called Descovy. Descovy is very similar to Truvada. The only difference is they kind of tweaked the chemicals that were in Truvada to make it less, to reduce some of the long-term toxicity. So I told you, HIV medicines, when you take them for years and years, can cause side effects, right? Bone and kidney problems sometimes. So Descovy reduces some of those risks. So that was the second option for PrEP. Kind of a lateral move, so it's less toxic, no more effective. It gives you kind of the same degree of protection. And for whatever reason, they did not study Descovy in heterosexual women. So technically, we shouldn't be, for heterosexual women, Truvada was still the only option until that time. So the next big change came 4 years ago. There was a medicine called cabotegravir or Apretude, which was the first injectable medicine to help prevent HIV. So this is, again, a medicine, you can use it to treat HIV, but it was studied as a preventative. And this was very novel in that you take an injection every 2 months, and these rates of prevention were off the charts. So the 70 to 90% was studied against Truvada. So it was that much better than even Truvada. So very active. And the reason for that is that if you expect someone to take a pill every day, some people are human, they forget. So some people don't always take it 100% of the time. If you give an injection, there's no pills. The medicine will be in your system, and the degree of protection is that much more. So this was a real game changer. The issue with this medicine has been, again, it's a new medicine. It's very expensive. So the access has been a little bit of a problem. Getting people that want it, sometimes there's insurance issues, financial issues, et cetera. But it's, again, an option. And then there's some people that just don't want to take an injection. It's a somewhat painful injection that goes in the buttock. Again, not terrible, but every 2 months you have to go get it. So the newest medicine for prevention is a medicine called Yeztugo or lenacapavir. Very similar to the other injection, except guess what? It's just an injection twice a year. So this is like the new blockbuster HIV drug on the block. This is the drug when I see my patients, the first question they ask me is, can I go on Yeztugo? So again, the statistics on preventing HIV are excellent. 95% risk reduction. Appears to be very well tolerated. Main side effect, again, you get the injection, you have some pain at the buttock. And that's kind of the state of the art in terms of prevention. So, I would encourage anyone, if you're interested in PrEP, the first thing is to talk to your doctor. There are a lot of primary care doctors now who are comfortable prescribing PrEP. Some aren't comfortable. If that's the case, that's when they'll refer to, someone like me or one of my colleagues, an infection doctor that can kind of manage that. The things to remember when you talk about PrEP is that it only protects you against HIV. Some patients think the injection protects you against everything. That's not true. So even if you take PrEP, you still have to try to have safe sexual practices, meaning using consistent condoms, trying to choose your partners wisely, right? So it doesn't eliminate the need to be careful, even though it does protect you against HIV. I urge everyone to try, get screened. HIV doesn't discriminate, doesn't care if you're old or young, black or white, homosexual, heterosexual, bisexual, whatever, Republican or Democrat, rich or poor, it's equal opportunist. So if you have any of those high-risk practices, I would implore you to get screened and not be in that 13% that walks around not knowing. All right. People at very high risk, I encourage them to go frequently. And what's frequent? Every 3 months. Go, get tested, get checked out. So we talked a little bit about HIV. That's not the only disease in town, right? There's lots of other STIs. I listed here, and STI stands for sexually transmitted infection. These are probably the 6 most common sexually transmitted infections we see in practice. The top 3 are all bacteria: gonorrhea, chlamydia, and syphilis. Gonorrhea and chlamydia are bacteria that most of the time when you get symptoms, they cause urinary symptoms, burning, discomfort, things like that. What you have to know is that sometimes they don't cause any symptoms. So there are patients that walk around carrying it and transmitting it to others and not knowing. Sometimes these bacteria can infect your throat or rectum. Sometimes they cause symptoms like a sore throat, rectal pain. Sometimes they don't. Again, that's how it kind of gets propagated. And we've seen a very dramatic rise in all 3 over the last 20 years. No one knows exactly why, but it just seems to have increased. They all, thankfully, are very treatable with antibiotics. The key, again, is screening, detection, and getting it taken care of. Especially in young people, gonorrhea and chlamydia can be devastating in that if a young woman gets it and it spreads into her uterus and gynecologic organs, it can cause infertility if it causes a more advanced infection. So another reason why it's important to encourage screening. The bottom 3 are the other common viral sexually transmitted infections. Hepatitis B has been described again since the 1970s and 80s. We don't have any good treatment. We don't have any cure for hepatitis B should you contract it. The symptoms of hepatitis B are usually, if you have it for a long time, it can lead to chronic liver disease. In some people, it can lead to end-stage liver disease, which means you develop cirrhosis, and you may even require a transplant. So it could be quite severe. Thankfully, there is a very effective vaccine for hepatitis B. So that's a vaccine anyone, again, at risk, all those risk factors we talked about before. If you fit any of those, I would encourage you to discuss making sure you get your hepatitis B vaccine. It's a 3-shot series, and if in most patients, it reduces your risk of hepatitis almost to 0. So very, very effective vaccine. Hepatitis C, on the other hand, is, again, blood and sexual transmission. There's no vaccine for hepatitis C, but there's a wonderful treatment for it, a treatment that cures patients like 95% of the time. Without treatment, hepatitis C, just like hepatitis B, leads to end-stage liver disease over the course of 10 to 20 years. So the key point for hepatitis C is screening. All adults, at some point, you should make sure your doctor has checked you, because sometimes you don't have symptoms until you've developed advanced liver disease. So if we catch it early, we can treat it and actually cure it.
That doesn't thing that they mentioned, because I just recently did my blood work.
Yeah.
And they told me that I have like fatty liver.
Right.
So is that something?
So fatty liver is a little bit different.
Okay.
Fatty liver is inflammation of the liver from a variety of causes. Now, if you have fatty liver and then you contract hepatitis B or hepatitis C, that's a bad mix. Then the liver, the progression to liver disease is even faster than it would have been. So people with pre-existing liver disease are also candidates that should be screened and be vaccinated for hepatitis B. Does that make sense? Yeah. And then the last virus is herpes simplex, right? Or is herpes, as most people will just say. So herpes causes painful genital ulcers. There's no vaccine for herpes. This is probably the most common sexually transmitted infection. There's no vaccine, unfortunately, and there's no cure. So again, the best measure is to use safe sexual practices, barrier protection. There are treatments in people that contract hepatitis B. It becomes a chronic infection, and oftentimes it'll cause ulcers recurrently over time. But there is medicine when you get the outbreaks to treat it. but there is no cure. So the best strategy, again, is to prevent it, try to avoid those high-risk practices. This is a graph showing kind of the rise in infections over time. So this is just those bacterial infections I was talking about, gonorrhea, chlamydia, and syphilis. There's over 3 million, over 2 million. This is 2023 data. It's even a little higher now. Chlamydia is the bulk of it, followed by gonorrhea and then syphilis. So I just want to illustrate the rise. Yeah.
You know what? I read magazine for old people,
Mm-hmm.
and they say through in old people
Yeah.
in the communities 55 plus, all these diseases are skyrocketing.
Yes, yes.
This is why where you have to read lectures, what's going on, because there is orgies every day.
Right. Well, look, no matter your age, you have to be careful, right? As I said before, HIV, gonorrhea, syphilis, they don't care if you're a senior or if you're a college kid, right? It doesn't discriminate. If you do these high-risk practices, multiple partners, not using protection, these are risk factors for you. So that's why I would say, they should get screened and they should be a little more aware of the risks they're taking, right? So this is kind of a summary slide. We talked about all this, right? How we have vaccine for hepatitis B, the gonorrhea, chlamydia, and syphilis. One thing I didn't talk about yet is something called post-exposure prophylaxis, right? Pre-exposure prophylaxis is preventing you from catching it. Post-exposure prophylaxis is you're exposed. Say you have, a spontaneous event, new partner, did not use a condom. What do you do to lower your risk of catching something? So there is something called doxycycline, which is an antibiotic we use for lots of different things. And it happens to have activity against gonorrhea, chlamydia, and syphilis. So if you take a dose of that after you have a high-risk exposure, it cuts the risk. Now, it doesn't eliminate the risk, so it's not like you're, scot-free. You still should get screened, but it lowers that risk substantially that you caught something. So that's another thing. If, again, anyone that's at risk should talk to their doctor about. You get a prescription for this medicine, keep it at home or with you, and then if the situation arises, you can take it to try to protect yourself from catching something. I mean, that was kind of the bulk of my talk. I kind of focused mainly on, things that, again, I don't think we don't always talk about or get translated. And I would encourage everyone, anyone that's listening or anyone that's here, when you see your doctor to talk about this. Some doctors may not, doctors are human. It's not always comfortable to bring up sexual infections and screening at a visit, though you should, that's part of the job. And it's well within your right to ask, should I get an HIV test? They're such simple tests to get.
My doctor always
Yeah.
asks,
Good.
like, do you want to take it? I always say yes.
Good, good.
Would that show also, my thing is always showing I'm on that fatty liver.
Yeah,
That's
yeah.
why I just
Right.
thought about it and asked him if he would want to give him medicine.
Right.
I said just change diet, and he gave me some for me to have more fish oils that would help you with your triglycerides.
Right. Now, you could ask them about hepatitis A and B vaccines. That's the only thing. If you haven't had it already, you should ask your doctor about that.
I'm not clear on, if somebody goes for annual physical,
Yeah.
you give blood, you
Yeah.
give urine, is that blood taken, is that screened for any of these? Or
No, you have to, the doctor has to order it. So they have to order, and again, the same blood they draw for your cholesterol and liver tests and A1C and all that stuff, they can use that to check HIV, hepatitis B, hepatitis C. The other tests for gonorrhea and chlamydia can be a urine test, and then syphilis is a blood test. So very easy test, nothing exotic. The problem is we just have to remember, the doctor should remember to ask about it and order it, and the patient should know to ask for it if they've had a high-risk encounter at some point.
The representative insurance says this test additional cost $50. Additional cost $100, and you got $500, they say no.
Right. I mean, most of these tests are not expensive. The screening tests are not expensive. usually insurance, if you have insurance, generally they get covered. That's usually not a barrier. The barrier usually comes with some of those more expensive medicines I talked about, the injectable medicines, things like that.
Yeah, but with the drug, does it, people who are on the HIV and
Yeah.
AIDS drug, does it respond differently to people? I mean,
You mean someone with HIV?
this is someone who's living with HIV. 'Cause
So,
I've heard that.
yeah, well, the good news with HIV, there's so many different medications. There's really no excuse for someone with HIV not to have control of their virus. Very little. I have very few patients. Years ago, when the medicines were even more toxic and tough to take, there'd be a lot of patients that just couldn't tolerate it, and they would not be controlled. These days, the medicines are so much less toxic, so much more tolerable. It used to be 20 pills a day to take 25 years ago. Now, most people take one pill, and there are some people that just do injections. They don't even take pills. So there's really no good excuse to not be well controlled. It's usually the fault of other factors that come into play, unfortunately.
How come this disease was only known from 80s? Before it was not diagnosed?
No, we think it only came in the late 70s. We think it started in chimpanzees and spread over into humans.
It's been proven.
As much as it can be, It's hard to be definitive about these things.
So in early like 1990, the medications was not as.
No. So,
I had a girlfriend that
yeah.
passed away pretty
Yeah.
It was in the early 90s. I
Ye-
remember I had my
yeah.
son, and then she shared it with me. She lived in
Yeah.
Boston, and then she shared with me that she
Yeah.
used to have multiple
The most famous person with HIV, is the basketball player. If you guys know Magic Johnson, I was in high school. I remember I cried. I thought he was going to die. He was one of my favorite players, and there he is getting HIV. Everyone was crying. There was a news conference, and you look at him now. No one says he has HIV. He looks healthy as anybody else. That's a testament to the medications we've had. Yeah.
I also know someone who went to the 90s contracted, and over the years, I mean, she's just like glowing.
Yeah.
She's gotten so much better.
Yeah. No. So.
She's an activist.
That's the thing. If you can find it, the person with HIV today, I tell all my HIV patients, I expect them to live just as long as someone without HIV, right? But at the same time, we don't, we want this epidemic to end, and unless we can root out all these cases and prevent, we're not going to make headway there. Okay.
What country after Africa stays?
Huh?
What country
Yeah.
after Africa has most?
I mean, there's pockets. It's a lot of countries that don't, or, unfortunately, it's poor countries that don't have resources. Things you mentioned, like Haiti. Haiti has very high rates. There's areas in the world like that. Yeah. All right.
How about China?
Huh?
How about China?
China is tough. They don't. We don't know their data, right?
Oh, in the same as
Yeah.
Russia. They
You don't know.
offer it.
You don't know the data.
Don't go
Yeah.
with the information
Right.
in your
Right.
pocket.
We don't know.
Oh,
Okay.
this is what it is.
All right. I mean, we have some time. I'm happy to talk about something else if you guys have any other questions.
Is this survey from you or from?
I think it's from the center. Yeah. Yep.
Is there a new medicine for AIDS? I think it starts, I don't know how it starts, but the generic name is Lenny.
Yeah. That's the medicine I mentioned that is for prevention. That's called lenacapavir. That's the injection we give every 6 months. That's the newest medicine.
I have a question.
Yeah.
It doesn't have to do with this, but
Yeah.
you're a doctor and it might give me some insight. So, like, I have like the fatty liver and the high level triglycerides. I'm trying to change my diet, and I cut out fried foods and stuff like that. Less rice, breads, things like that. Dieting. But my doctor, and because I have now like knee problems, so I went for like my gel shot, and I don't want to do like any like surgery. I'm trying to avoid that. So my question is, what are your opinion on these injections that I don't want to take them?
Yeah.
I sent to my pharmacy, and then I decided not to pick them up.
Yeah.
These Ozempic
Yeah.
and all these things. I'm not too crazy about it, and
Yeah.
no, it works, but in the course of what? You know what I mean?
Well,
the
look,
risk.
I think, look, I'm not a specialist in that. Let me put the disclaimer. I think the bet in all those medications is that the benefits you get from the weight loss is so great that, there may be some side effects down the road, but we're betting that the gain is so great it's going to outweigh those risks down the road. I think that's the way a lot of the doctors look at it. And it is a forever drug. So those medicines, it's not like you take it for a year and stop. You take it as it stands now, you take it forever. Yeah. But we're betting that there's so much benefit to losing the weight that it'll outweigh, if we do find some effects down the road.
Yeah, because I was very skeptical about it because
Yeah.
I have thyroid, so I take medication for my thyroid.
Yeah.
And one of the side effects is like I have like nodular thing, and I took the
Right.
sonogram. My doctor said you're fine, but I'm like still very hesitating.
Yeah, that's a tough choice. Yeah.
But
Yeah.
you said
But like I said, from the doctor's standpoint, we expect the benefits because you said your arthritis might get better, your
Yeah.
fatty liver get better, all these other things, triglycerides get better. So all those benefits, versus what maybe side effect in how many years, right?